Hey everyone, welcome to this high-yield NCLEX explainer. Today we're tackling a high-stakes, absolute clinical thriller of a disease, Guillain-Barré syndrome, or GBS. If you're prepping for your nursing boards, this is one of those must-know neurologic topics that examiners just love to test, mostly because recognizing it quickly is literally a matter of life and death. Okay, let's dive right into this. Picture this. Your patient's legs start feeling weak, kind of tingly. Next thing you know, they can't walk. Then, they can't even move their arms. It's this creeping paralysis that starts right in the feet and aggressively climbs up the body. And the absolute terrifying question for us as nurses is this going to reach the muscles that let them breathe? Because that is the grim reality of Guillain-Barré syndrome. Phase 1, the ascending threat. So to really master GBS, we've got to understand this bottom-up chain reaction. It's an acute autoimmune attack, right? But it doesn't just happen out of the blue. Step 1, there's almost always a recent infection, usually about 1 to 3 weeks prior. We're talking a GI bug like Campylobacter jejuni or maybe a respiratory virus. Step 2, the body's immune system gets totally confused. It's an autoimmune cross-attack. The antibodies meant to fight the infection mistakenly target the patient's own peripheral nerve myelin. Step 3 is that demyelination itself. That protective myelin sheath gets stripped away, which basically blocks or super slows down those peripheral nerve signals. And finally, step 4, ascending weakness. Remember, this is attacking the peripheral nervous system, not the central nervous system. So it starts distally, way down in the legs, and just works its way up. Phase 2, signs and symptoms. As we run through these clinical hallmarks, I want you to mentally visualize these symptoms spreading from the toes upward. First off, the weakness is ascending and it is totally symmetric. Both sides of the body get weak together, from the ground up. You're also going to see paresthesias, that classic numbness and tingling. Next up, and this is a massive clue for your exams, diminished or completely absent deep tendon reflexes. We call it areflexia. The body just flat out stops reacting. And as that paralysis climbs higher, you'll start seeing facial or bulbar weakness. Basically, the patient will have trouble swallowing, which, as we know, opens the door wide open for aspiration risks. Phase 3, the danger zone and priorities. Okay, listen up, because this is the absolute most critical NCLEX concept for this entire topic. Danger, respiratory failure. As that ascending paralysis climbs higher and higher, it eventually hits the diaphragm and the intercostal muscles. And the second that happens, the patient loses the mechanical ability to breathe, period. Your absolute #1 nursing priority is monitoring their respiratory status. You've got to keep a super close eye on their serial vital capacity and forced vital capacity, or FVC. If you see a falling vital capacity paired with a weak cough, that means impending respiratory failure, and you better have intubation equipment ready to go right then and there. Now, how do we actually confirm this? Well, the provider is definitely going to order a lumbar puncture. When we look at that cerebrospinal fluid, or CSF, there's a signature GBS finding. The CSF protein will be elevated like sky high, but the white blood cell count, totally normal. High protein, normal cells. Clinically, we call this albuminocytologic dissociation. It's a fancy term, but it's a classic hallmark that you will absolutely see on your exams, so definitely lock that one in. All right, so how do we rank our nursing interventions? It all comes back to the ABCs: airway, breathing, circulation. Number 1, like we just talked about, is monitoring respiratory status and vital capacity. Airway wins every single time. Number 2 is monitoring autonomic function. GBS froze the autonomic nervous system completely out of whack. We're talking wild blood pressure swings, arrhythmias, tachycardia. You need them on continuous cardiac monitoring for sure. Number 3 is giving the mainstay treatments, which are plasmapheresis or IVIG. And number 4 is DVT prophylaxis. You've got to prevent the complications of immobility with things like skin care and a range of motion, because remember, this patient is entirely paralyzed. Phase 4, management and recovery. So let's talk about actually treating the underlying disease. To shorten the whole course of GBS, we go with plasmapheresis or intravenous immunoglobulin. You'll see it as IVIG. Plasmapheresis physically filters out those attacking autoantibodies from the blood, while IVIG basically neutralizes them. Now listen closely to this part because it is a huge NCLEX trap. Corticosteroids are not generally effective for Guillain-Barré syndrome. They are not the mainstay treatment here. So please do not fall for that on a multiple choice question. Finally, we do supportive care and rehab. The really good news here is that GBS is usually reversible. The catch? Recovery is super slow. It takes weeks or even months as that myelin slowly repairs itself. Phase 5. NCLEX test yourself. All right, let's make sure this knowledge is totally locked in. Question 1. A client with Guillain-Barré syndrome has ascending paralysis now at the level of the mid-chest. The nurse's priority assessment is A. Respiratory function and vital capacity, B. Deep tendon reflexes in the arms, C. Pupil size, or D. bowel sounds. Drop your guess in the comments. 3, 2, 1. And the correct answer is A. As that paralysis creeps up toward the mid-chest, the diaphragm and intercostal muscles are in immediate danger. Respiratory failure is the biggest threat here, so checking respiratory function and serial vital capacity is absolutely your top priority. Let's try question 2. Which treatment is used to shorten the course of Guillain-Barré syndrome? A. Long-term corticosteroids alone, B. High-dose diuretics, C. Antibiotics for all clients, or D. Plasmapheresis or IVIG. Lock it in. 3, 2, 1. The answer is D. Plasmapheresis and IVIG are the mainstays that either remove or neutralize those autoantibodies causing the demyelination. Remember that trap we talked about? Steroids are simply not the answer here. To wrap this whole thing up, I want you to take a screenshot of this and literally burn it into your memory. JBS equals goes bottom up, symmetric, and always, always watch the vital capacity. If this made it click for you, subscribe. We're doing one killer med-surg topic every single day until you pass the NCLEX. Keep studying hard, and I'll see you in the next explainer. Though honestly, it does kind of leave you wondering, what other catastrophic misfires is the human immune system actually capable of?